Welcome back everyone to another Hirad EP videos. Today we're going to talk about atrial fibrillation guidelines again. So this is a part 2 and the focus today will be on pharmacological cardioversion of patients with atrial fibrillation. As you know, we have these series of reviewing the guidelines for atrial fibrillation published in 2023. And basically today we have the second part of it about pharmacological cardioversion. So let's start with the recommendations for pharmacological cardioversion. As you know, we use it when the patient is hemodynamically stable. And if the patient is not stable, you need to do electrical cardioversion since the pharmacological cardioversion takes time. There are two ways of providing these medications to the patient. One is intravenous, such as in a case of ibutylide, amiodarone, and procainamide, and also the pill-in-the-pocket strategy that we use it for medications like flecainide and propafenone, as well as amiodarone PO. Although amiodarone PO will take a very long time to work, so it's not necessarily considered as an agent, the PO form for pharmacological cardioversion. Now, you need to know that we have level of evidence A for ibutylide, and the only thing you need to remember, do not give it to the patient with ejection fraction less than 40%. And that's because increased risk of torsade de pointes significantly. We're going to go over about how to give these medications on the next slide. So the second one we just mentioned, it was intravenous amiodarone with the basically longer half-life than most of these agents. And the third one is a flecainide propafenone class 1C group that is part of the pill-in-the-pocket strategy. We usually give a single dose of flecainide or propafenone, and it's important to remember that give it with AB nodal agent like calcium channel blocker, like beta blocker, because you're always worried that Afib slows down and converts to the fast flutter and conducts one-to-one and cause more trouble. Another thing is that is important for this pill-in-the-pocket strategy is recommended that is given at least one in a monitor setting. And if the patient passed the test, means tolerated the medication, nothing bad happens, and patient was okay with that flecainide propafenone in the monitor setting, then the patient can get it as an outpatient at home when the atrial fibrillation episodes came back. And then lastly, the class evidence is 2B. These are the patients with, especially if they have a pre-excitation that you don't want to use amiodarone or other options, you can use procainamide or ibutylide for in case they're in atrial fibrillation and pre-exciting. But overall, procainamide is not an agent that is recommended as a first line of treatment for pharmacological cardioversion. So this is a very interesting table. As you see, has a lot of information about route of administration, what the loading dose, maintenance dose is, how long it takes to work, and then how is eliminated, what is the half-life, and what are important things, major side effects and adverse effects that you need to remember when giving these medications. So on the top is amiodarone, which we give it at intravenous form. We talk about the PO, rarely used as a pill in the pocket because it takes forever. The IV amiodarone loading dose is usual that we use for VT as well, is a 300 milligram loading dose, and then you put a drip continuously. And it takes about 8 to 12 hours on average to convert back to the sinus. And as you know, it has a very, very long half-life, up to 9 to 35 days. And the important things for them is amiodarone, still remember that can cause torsade de pointes, so you need to be careful about QT prolongation. Especially you need to remember that amiodarone, if you give it in the setting of patients on ibutylide or procainamide, might increase the chance of QT prolongation more. There are some data about amiodarone ibutylide that has some safety, but that is a small sample study, and we always need to be careful about giving medications that prolongs QT because they might have additional effect. Sometimes cause phlebitis, intravenous phlebitis of the vein, so that is an issue, and a hypotension and bradycardia is another issue with IV amiodarone. If you give it slower, you can minimize the effect of bradycardia and hypotension. The second group here is flecainide that we use the oral form in the United States. We have an intravenous form in Europe, and also there is an oral inhaler flecainide that is getting phase 2 and phase 3 trials, undergoing trials, and it might be available as one of the interesting options so the patient use oral inhaler flecainide. And then basically what the dose is used is a single dose, is a 300 milligrams if your weight is more than 70 kilos. Same in the family is a propafenone. We have oral. These are the pill in the pocket strategies, and you take 600 milligrams if the kilos is more than 70. So propafenone 600, flecainide 300 milligrams, and remember that as we mentioned in the previous slide, you want it to have one time monitored in the hospital setting or in a monitor setting to see if the patient can be tolerated, because sometimes they have side effects, up to 70%. Some of the studies shows that patient get side effects and issues, and then they might convert to atrial flutter and the fast one. That's the reason you give a beta blocker as well, or calcium channel blocker, to make sure this doesn't happen, the fast conversion of the atrial flutter, one-to-one conversion. And as you know, these are class 1C family. They can exacerbate heart failure, and they usually widen the QRS, but they can prolong QT, so you need to be careful about that. And another thing that is particularly important for propafenone is some sort of metallic taste or taste disturbance that can be associated with propafenone. The interesting things about them is they have a relatively good efficacy, around 50 to 60% efficacy for flecainide, and something around 50%, a little bit less for propafenone. But both of them starts working around 3 hours, and sometimes sooner, sometimes later, but on average it takes about 3 to 8 hours. So IV amiodarone 8 to 12 hours, flecainide and propafenone 3 to 8 hours. The fastest and basically most effective one is ibutalide, that takes about 30 minutes to work. And usually we recommend to give magnesium before, 1 to 2 grams IV magnesium about half an hour before, if it's possible. That decreases the risk of torsade de pointes. Although the elimination half-life is 2 to 12 hours, it is recommended that monitor the patient for 4 hours after IV infusion of ibutalide. And usually we wanted to give a 1 milligram of ibutalide for people with weight more than 60 kilos. We give it in 10 minutes, and then we assess. There are some recommendation about give a second dose if the first infusion was not successful. It depends on basically the patient's weight as well. But the most effective one and the earliest response that you get is from IV ibutalide. IV procainamide, as we talked about it, also is a class 2B recommendation, because although it has like 30 to 60 minutes conversion time, it works fast like ibutalide, but it's not as effective. It's almost half or 1/3 effective as ibutalide. And we keep it for the patients, for example, for pre-excitation. They have about 3 to 8 hours of elimination half-life, although they have this N-acetyl procainamide combination chemical that it can have some effect of procainamide, including prolonging QT, and they can last for 7 hours. Usually, it is recommended to give 1 gram over 30 minutes. We tend to give it less because we see a lot of hypotension. Up to 20% of the patient might get hypotension if you give it larger dose. And also, you need to be careful about issues with the bone marrow issues and effect of the blood counts, platelet counts, rash, and things as such that we see with procainamide. Okay, and this is the last slide, and the most important slide. I want you to remember this. So if somebody comes with atrial fibrillation, hemodynamically stable, and you wanted to use medications, rhythm medications, to convert the patient back to sinus rhythm, you look at a few features. If the patient has a normal LV function, so if left ventricular function is normal, you can use IV amiodarone and ibutalide. As I said, ibutalide is better to give some magnesium initially and then infuse in 10 minutes 1 milligram, and be careful for and watch for QT prolongation, at least monitor the patient for 4 hours. If the patient has has pre-excitation. In particular, procainamide is a better option, although albuterol is also a very good option for those patients as well. Now, if the ejection fraction is less than 40%, then you have only option of IV amiodarone, because albuterol is contraindicated or cautious. You need to be cautious, and it can prolong QT significantly in patients with the cardiomyopathy. And procainamide also can exacerbate heart failure and has some negative inotropic effect as well. If the patient is calling you from outside the hospital, you want the patient's at home and already received flecainide or propafenone in the monitor setting, you can try flecainide and propafenone as a pill in the pocket strategy. Flecainide 300 milligrams if the weight is more than 70 kilos, and propafenone 600. And that's about it.